Where for last 2 days we are talking regarding the atherosclerotic disease, coronary artery disease. Now I am talking the inflammatory disease of coronary artery and how we'll manage this thing. So the Takashi arteritis is inflammatory disease with special predilection to young female involve the coronary artery as well. And here you see the two sisters in the same family, and there is some subclavian artery block on both the side and left carotid block. So much devastating disease. We recorded 650 cases, among which 274 were done the angioplasty, among which we classify the different site involvement of the Takashi arteritis, different vessels. The coronary involvement we classified a class 4. Also, you are already published in JAC 2097. So we recorded 65 cases, among which surgery done only 15 cases, and coronary angioplasty done 10, and 40 cases medical therapy. Takashi arteritis is a coronary involvement. Takashi arteritis, it is a vasculitis that affect the outer and middle branches. Coronary involvement consists mostly of stenosis, occlusion of the coronary ostium, and it is 73% cases. Non-ostial involvement 18% cases. As a whole, the 10% incidence of coronary involvement for the whole world literature. So regarding the pathology, narrowing of the coronary arteries is mainly due to extension of the inflammatory process of proliferation of intima and contraction of fibrotic median adventitia of ascending aorta. Now we are classified when the ostium or the proximal artery occlusion, the type A, when the diffuse multifocal lesions, type 2, when there is the aneurysm formation, you see, type 3. Now, when the patient coronary involvement presented with hypertension and abdominal bruit, sometimes present with marked infarction, heart failure. This is my patient, 24 years old female, presented with upper limb hypertension. Here is the shadow on the left side, thoracic aorta involvement, and on the right side, the LMCA ostial lesion and proximal LAD narrowing is there. Now, how will manage this patient? Either is the angioplasty or some CABG or medical therapy. That should be, but medical therapy is sometimes very useful also. This is my patient here, 21 years girl, presented with unstable angina in case of Takashi, where the thoracic artery involvement, both subclavian block, left carotid aneurysm there, and here the that right coronary artery shows the block of the left coronary artery, so block of the ostium as well as the shaft of the LMCA and proximal LAD. Next slide. Now we have to do the angioplasty. We are cross the lesion, and where cross the lesion, the shaft is there as well as the proximal LAD also lesions. Next, first initially after placing the wire, we dilated the shaft as well as proximal LAD with help of the plain balloon. Then we use the cutting balloon. Balloon was used, very useful balloon for cutting the LMCA, the left main vessels here. Already cutting is done. Then we have deployed the stent. Then deployed the stent from ostium of the LMCA. And when the guiding catheter is away from the ostium, you see, the stent is, I use the onyx stent from the ostium and 1 to 2 millimeter inside the aorta and reach up to the proximal part of the LAD. Next. After that, we deployed the stent at slowly at the ultimately 18 atmospheric pressures, and where guiding catheter is 2 millimeter away from the ostium. Next, after proper deployment, now slowly we are inflating the stent and deployed at the 18 atmospheric pressures. Then after deployment, you see, appreciable result is there. After that, I post dilatation with the help of the NC balloon. LMCA, I have taken 3.5 NC balloon. You see, after post dilatation, then after flaring of the mouth of the LMCA is also done. Next. And here, flaring, we are trying to flaring of the ostium when the guiding catheter far away from the ostium. Now you see 3.5 millimeter, the NC balloon also dilated LMCA as well as the up to ostium with the excellent result. Next, the final result of this LMCA dilatation as well as the proximal LAD improve with the acceptable result. Next important case where we're talking to the appreciable result of the LMCA and as well as the proximal LAD. Next interesting case is 19-year-old girl presented with the chest pain and hypertension. Here the hypertension due to bilateral renal artery stenosis, justa renal abdominal aorta severe narrowing. And you see angiography of the patient presented unstable angina. Angio shows ostium of the right coronary artery about 90% block and proximal RCA also narrowing. And here, then we first negotiated the wire in the RCA and then use the cutting balloon. I use the angiscap in this patient, right coronary artery, and after repeated dilatation, still very difficult to cut the fibro inflammatory lesions of the proximal RCA. Then I place the stent from the RCA to the ostium, where the guiding catheter far away from the aorta. So 1 to 2 millimeter of the stent is placed in the aorta. Next, then we give the full dilatation of the stent, post dilatation by the NC balloon, and ultimately we have done the flaring of the ostium of the RCA. Next. Now the flaring of the whole right ostium is dilated here, where the at least 2 millimeter of the stent away from the ostium and guiding catheter on the aorta. After that, final result, final appreciable great result of the ostium is fully dilated, you see, and good result in this patient. So the patient of follow-up, we have the 6 years follow-up done, and patient only the out of the 10 patients, 2 patients developed the stenosis. Now conclusions, marked infarction in case of Takashi arteritis, rare entity. So inflammatory disease also inform the coronary artery. It is a disease of young female with prolonged duration of disease, and ostial and proximal lesion of the coronary artery most commonly involved. It may be clinically silent initially, and until you have to doing the procedure of the angioplasty, measurement of the disease activity at the time of presentation very important. Multifactorial approach is required for this management. Intervention should be preserved in selected cases. That is why out of 65 cases, we have done the 10 cases angioplasty only done, 15 cases we have do the surgery, 40 patients we have the medical therapy. And therefore surgical intervention better than the percutaneous coronary intervention, because the restenosis is very high. Out of our the 10 patients, and the 2 cases developed restenosis after 1 year. So DSA is a new generation stent, is a better option for the angioplasty. I told you that restenosis in our series is 20% cases with particularly during the PCI, because cause of restenosis, the disease of aortic arteritis is not a static disease. Is the symptoms is worsening and waning of the symptom in spite of the steroid. But to prevent the restenosis, we use the 60 milligram steroid initially along with the methotrexate 50 milligram. And after 6 months, up to we continue the methotrexate and the steroid to continue at the lower doses up to 5 milligram up to 1 year. So we have got the appreciable result. 8 patients doing well, 5 years follow-up, and only 2 cases restenosis. Thank you very much for patient hearing. So this is the rare disease. Still speaking from India, this past report.
Okay, thank you, Professor Panja, for showing us very excellent cases, coronary artery disease, particularly in the acute setting in the Takayasu disease. One thing I'm just like to know from you that most of these Takayasu disease cases involving the coronary artery, they have got very tight and fibrous lesion. So whether they require high pressure while you are deploying the stent, they require the high pressure for the stent deployment?
Yes, correct. Initially, where NC balloon inflated. In that cases, where not NC not sufficient, then I use the cutting balloon. Bulgarian cutting balloon I use all 8 cases, and 2 cases plain balloon, NC balloon sufficient. So therefore, lesion preparation, most of the cases we use the cutting balloon. After that, NC balloon once again, then put the stent. Because the osteal lesion 80% cases, so precaution to be taken just not to damage the stent. So after putting the wire inside the LMCA, then guiding catheter little far 2 millimeter away, and again the stent also 1 to 2 millimeter in the aorta and outside the ostium of the stent. That is special precaution taken. After that, a pulse is given, and even flaring of the mouth of the ostium of the both right coronary left coronary done routinely.
Another issue, Professor Panja, I think that these particularly group of patients may have the tortuous lesion.
No, actually, tortuous lesion is not common. Particularly here, atherosclerotic tortuous, most of the cases may be seen. But here, atherosclerotic, because proximal lesion and particularly osteal lesion, no tortuosity we have not observed. Of course, in the extra coronary, some cases on the carotid and subclavian artery, both tortuous, even aneurysm formation. In this my study, 3 types I mentioned, the type 1 of coronary involvement, where the ostium and proximal LAD, a proximal lesion. Second, type 2, where the distal lesion and focal, all non-osteal lesion. And again, some cases, third type of lesion, the coronary aneurysm can be seen, sacral aneurysm or fusible aneurysm seen. That is the follow-up period.
You have mentioned that you have used the steroid and also methotrexate.
Yes.
When they are being used?
So routinely, after doing actually before starting of the patient some activity of disease, prior to the angioplasty, we have to combat the inflammatory lesion first. We assess the Pianka, Sianka, and ESR in a routine study, and you have to control the inflammations with the help of the steroid as well as the methotrexate. After some suppression of the activity disease, then we do the angioplasty. But the 3 cases, activity you cannot control, but patient getting pain, ongoing worsening symptoms, and unstable. In that case, in spite of the activity, we done the angioplasty. That is why this response is high, many cases.
Thank you, Professor Panja. I invite some comments or questions from the other participants.
Good evening, sir. This is Dr. Karnakar.
Yeah.
So, between surgery and intervention, how to choose a case in a given case? How to choose?
Okay, actually, definitely very right questions. That depends on the anatomy of the patients. If the proximal lesion, osteal lesion, we prefer to do the particularly angioplasty. But it is the multiple vessels. If right coronary artery, left coronary artery, LAD, ostium, multiple vessels, that case you use to take the surgery. You see, if it is a single vessel disease, I have taken the single vessel disease. One case is I presented you right coronary artery, another case LAD. But this bilateral coronary artery involvement, multiple vessel involvement, so that case you taken the surgery. Just like a multiple vessel disease.
Thank you, sir.
Definitely, okay. CAP is a better option, no doubt at all. But a single vessel disease, that case I prefer to this day. So out of 65 cases, the 10% out of 650, the 40 cases I repeatedly told you, that is the 15 cases surgery, 10 cases angioplasty, remaining 40 cases medical therapy ongoing.
Repeat revascularization are more common in this group.
Yeah, that's good. Repeat revascularization common. But on a follow-up 2 cases stenosis, we use the again cutting balloon for stenosis. That case is, and last case cutting balloon again followed by the drug-eluting balloon. I use it.
Okay, thank you.
Thank you very much.
Thank you, Professor Panja, for sharing your experience of a very fascinating and important issue, involvement of coronary artery disease, particularly in the young age with Takayasu's disease. We have a very good sessions. First, Praveen Chandra, he shared his experience with new stent. Then the robotic surgery. Then we came to some intervention, some cases of intracranial intervention, both the CVST and the aneurysm of the intracranial artery. And Professor Panja, he is a master internationally for the dealing with Takayasu's disease, and he enlightened us for the intervention of coronary artery disease in Takayasu's disease. There is no presenter with these few words, and expressing my sincere thanks to all the presenters. Here, I conclude this session. Thank you to all.
Thank you, Dr. Banerjee, for conducting the nice session. Thank you.